Okay, now we are officially starting Unit 5, Class 4 Zoom session. This is our last class prior to the exam, but if you saw the Plato announcement, I am offering an exam review prep kind of push session on Monday morning at 8:30. The reason I'm doing it at 8:30 is because I understand those of you taking topics have a Zoom with Mrs. Weaver starting at 9:30. So I wanted to make sure I wasn't interfering with that. Again, that session will be recorded and uploaded as all of them are, but I just wanted to highlight because that's a change in the time that we would typically do that. But let's go ahead and get started for today. I do have quite a bit I want to get through, but let's start with the actual going over the quiz. And then I do have things in a PowerPoint that I just kind of combine some stuff to kind of work through. And then of course, any questions that people have at the end, I'll go through and answer those. So that's kind of going to be the format for today. So let's start with the Unit 5C4 quiz. So this was all true false, I believe. So patients should be instructed to drink plenty of fluids after venography. That is true. Venography uses a dye. It's not the same type of dye that they use for like a CAT scan contrast, but it's still dye that's injected intravenously, and it does still have to be processed and excreted by the body. So we always want to push fluids after any type of procedure administering that so we can get it out of the body faster. Next question, venous stasis is a factor in Virchow's triad, and that is true. When we talk about DVTs, venous stasis is a factor, and it's actually the most critical factor in the development of DVTs, which is why we talk about all the preventative ways to avoid DVT, making sure your patient is getting up and walking every 1 to 2 hours while awake, making sure they're doing those leg and ankle circles and leg pumps to help stimulate circulation return, the TED stockings, the SCDs. It's all important factors in trying to promote venous return so that blood is not staying there and likely to form a clot. Okay, question 3, protamine sulfate is given to counteract the effects of warfarin. That is false. Protamine sulfate is the antidote for heparin, okay? The antidote for warfarin is vitamin K. And we'll talk a little bit more about both of those medications today. Question 4, a platelet count of 450,000 indicates an adverse reaction to heparin. That is false. One of the adverse reactions to heparin is what we call heparin-induced thrombocytopenia, which would be a decrease in platelet counts below the normal values. Okay, so a normal value of a platelet count of 450,000, that is not an adverse reaction to heparin. Okay, titration of heparin drip rates are based on APTT or anti-10A assay levels. That is true. We're going to spend a lot of time today going over heparin drips, just kind of making sure you have a handle on that. But yes, when you're talking about IV heparin that we're giving, via IV, we are titrating or adjusting that drip rate based on lab values. Next question, warfarin will slowly dissolve a small thrombus. That is false. Anticoagulants do not dissolve clots. Okay, they do not dissolve clots. They are solely given to prevent increase in size of the current clot or the prevention of the development of additional clots. Okay, heparin can be administered subcutaneously, intravenously, and orally. That is false. It can be given sub-Q, it can be given IV. Heparin is not given orally. Next question, pallor and a dorsalis pedis pulse of +1 out of 4 indicate venous insufficiency. That is false. Those signs and symptoms there indicate an arterial problem, not a venous problem. And we'll chat a little bit more about that today, just so you can differentiate between the two. Next question, nicotine affects circulation by causing vasoconstriction and vasospasm. That is true. So smoking nicotine is a huge factor in the development of peripheral vascular disease and also Raynaud's phenomenon. So we'll talk a little bit about that. And finally, enoxaparin should be administered subcutaneously in the arm. That is false. Enoxaparin is the generic name for Lovenox. It is administered subcutaneously, but when you're giving an anticoagulant subcutaneously, it must be given in the abdomen, at least 2 inches away from the umbilicus. Okay. All right, so now that we have gone over the quiz, let me switch up. Well, first of all, does anybody have any questions related to the quiz specifically? And then I'll just kind of go through the content. Maybe I'll hit your questions as we're going through the content here. All right, let me X out of that. I have to share my screen here. Getting a little bit more proficient at this Zoom thing. It's happening. Okay. So at this point, everybody should be able to see my screen. Let me just move some stuff around here so I can get it into slideshow mode. Okay, here we go. All right, so this Zoom is just to specifically focus on Unit 5, Class 4. So we're gonna hit vascular disorders. We'll talk about the different vascular ulcers. We're gonna do a medication focus. I'm also gonna be reviewing heparin calculations. And at the end, I do have a little bit of an ABG review because there were some students that had asked for that, just a little bit more clarification. So I wanted to hit that. And there are also some NCLEX questions because that was also by student request. So we're gonna roll through this. Okay, so I just wanted to talk a little bit about vascular disease and specifically to leg ulcers. And as you go through the material, the reading, the pre-class captures, and also that class PowerPoint, it talks about how you differentiate an arterial problem versus a venous problem. And if you go back to basic anatomy and physiology, arteries carry blood away from the heart, okay? So when we talk about peripheral arterial disease, the issue or the problem is with getting that oxygenated blood down to the periphery of the body. In this case, down to the toes, down to those tissues down there, okay? Whereas if it's a venous problem, I don't have a problem getting the blood down there. It gets down there, that oxygenated blood is feeding those cells, they're happy cells. The issue is with getting the blood back to the heart. So the blood pools, that causes pressure in the vessels. You can have stretching of the vessels that causes venous stasis, so you can have development of clots. And basically that pressure, that clot formation, it causes damage to the skin, and that's where you can develop these venous ulcers. So a couple ways that you can kind of differentiate between arterial and venous leg ulcers, it all goes back to assessment. So if you're thinking about an arterial issue, those wounds are going to typically be on the toes, a lot of times at the top of the toes. They're going to be very circular and small in size, diameter-wise, but they tend to be very deep. The other things that you're going to see with an arterial problem are going to be signs of impaired circulation. So their color of their extremity might be very pale, okay? When you touch it for temperature, it's going to feel cool or even cold. Peripheral pulses are going to be diminished, +1, or maybe even non-palpable at all. Now we talked about in the hospital, before you document that a pulse is truly absent, you should be checking it with a Doppler. But if you're assessing this at home, or you're assessing in a place you don't have a Doppler, then it's going to be 0, it's non-palpable, okay? The other thing that you'll see is a lot of times their lower extremities, particularly the shin areas, the anterior shins, will be shiny, and there will be a lack of hair growth. And you see this a lot, particularly in males as well, where, they might have hair in their upper anterior thighs, and then they get below the knees and it's like completely shiny and no hair growth whatsoever. That, coupled with the other things we talk about that indicate a lack of circulation, are very, very classic signs of peripheral arterial disease, okay? Now, on the venous side, remember that the blood flow is getting down to the extremities, okay? So it's not going to be pale. In fact, when you look at the coloring of the skin, it's likely going to be perhaps even like a reddish, a purplish, or even a brown discoloration. And that is from that pooled blood and pushing against the skin. Basically, everything's kind of there. So it causes that discoloration. That's very classic of your peripheral venous disease. Okay, so it's very important. I've been using several terms. When we talk about peripheral vascular disease, that is a broad umbrella term that covers arterial issues and venous issues when we're talking vascular. So when you're talking about these more in particular, you want to be, is this arterial? Is this a peripheral arterial disease? Or is this a peripheral venous disease? Where exactly is the problem in our anatomy? Now, when you look at venous ulcers, these tend to be very, very big, large in size, diameter. They tend to progress very quickly. The other thing, they tend to be like at the malleolus, they tend to be, you know, on the top of the ankles and that sort of thing. So they get to be large, and they're not quite as deep. When you talk about depth, they're not as deep as your arterial ulcers. The arterial ones tend to be smaller in diameter, circular, but they're deep. Your venous ones tend to be larger in diameter, but they're not as deep. So those are things to kind of look at to differentiate that. Again, in relation to the other signs and symptoms and how does the surrounding skin and that look. You also want to be aware of the presence of any type of infection. So what does the actual wound look like? What does the wound bed look like? Is there drainage? What type of drainage is it? Is it purulent? Are there signs of infection there? Okay. Obviously, anytime somebody has a break in skin integrity, our goal is to restore that. Okay. All right. So let me answer some questions here that just popped up as we were talking. So can a patient have both? Yes, they actually can have both. You can have venous dysfunction and you can have arterial dysfunction. So our biggest concern with arterial dysfunction is you have a lack of blood flow down to those tissues. So essentially those tissues are going to become hypoxic, it's ischemic, and eventually those tissues literally will become necrotic and kind of rot off. Okay. Now the venous side, again, the pressure in the venous side is lower. So in doing that, when the pressure in the venous side is lower, it's going to, it takes contraction of the muscles to try to promote that venous return. So when that is not happening, that blood pools down there. So you can get both. Now, the edema in the ankles that, Hannah, you're referring to, edema in the ankles isn't always necessarily related to vascular disease. It could also be related to a heart failure, because if your right ventricle and your left ventricle, but really if your right ventricle is not keeping up with the amount of circulating volume and the blood backs up, that's where you see that bilateral, particularly lower extremity edema, that tends to be more dependent edema. Okay. Next question, patient who appears to have cellulitis on their legs potentially have the start of venous disease ulcers? Absolutely, they absolutely do. And patients with cellulitis, particularly if it's related to peripheral venous disease, it's because you have that pooling of the blood, pooling of the fluids. Well, you know, when you have too much of that down there, that's going to increase the risk for breakdown of skin integrity problems. And as soon as you have a break in skin integrity, whether it's from a scratch, whether it's from a fingernail, cat scratch, anything like that, any type of portal of entry that bacteria can get in, if you already have a cellulitis, we're really just primed for a pretty nasty ulcer, a really nasty leg ulcer. So this is definitely a very, very big issue. Venous ulcers can have clear drainage. So we're kind of talking some different things here. When you have somebody who has very edematous legs, okay, we're talking like +4 pitting edema, or even more edema than that, to the point that it becomes non-pitting because it is so saturated with fluid, those legs can start to weep. So anytime that you have moisture, you know, whether it's an incontinent patient, it's moisture from edema that is weeping, that is going to put your patient at risk for skin breakdown. So when you talk about venous disease ulcers, we're talking two different things. The actual ulcer itself, it's moist. The bed is moist. So you're going to have some serous and clearish type drainage with that. However, when you're talking about it being infected, that's when you're going to see some more purulent drainage. But that's different than the weeping of the legs. The weeping of the legs, when you have somebody who's so edematous, that's just simply because there's so much fluid in there, it can't stay in and it starts weeping out the skin tissue. But that moisture is going to put them at risk for developing developing an ulcer if there's not one already there. So what situations will we call the healthcare provider with venous ulcers? I'm assuming you mean like call the healthcare provider like as a priority. Generally, these things are not a priority unless the patient is showing signs of systemic infection. Okay, because then we're talking, you know, potential sepsis and how it's affecting the rest of the body. These ulcers, these vascular ulcers, these are chronic problems. They didn't happen overnight, and it's not going to be solved overnight. These patients require extensive wound care. A lot of times they're seen at the wound clinic. We may use special types of dressings. A lot of times they might use vac therapy, the wound vac therapy. One of the newer, I don't really want to say newer, we've been using it for a little bit, but hyperbaric oxygen therapy, hyperbaric chamber therapy, trying to increase the oxygen delivery to the actual wound tissue, the wound bed, to promote healing. But these are chronic problems. So in general, you know, it's not going to be a priority to call the provider with these as long as it's known. Now, if this is a new patient that came in, has never been seen by the provider, and you're doing that admission assessment, your documentation is critical. How you describe this wound, how you're measuring the wounds. Some facilities will actually take pictures of the wounds and include them as part of the EHR, just to provide that documentation. Obviously the provider would need to be notified about that. But when it comes to like a priority type notification, these are generally chronic issues. So unless it's become a life-threatening situation for your patient, it's not something I'm going to pick up the phone at 3 o'clock in the morning and call the provider. Okay. Now, that being said, our focus with this is really about restoring skin integrity. We want to obviously promote circulation, whether it's arterial circulation or venous return. And the other thing we need to do to help restore skin integrity is look at this patient from a nutritional standpoint. Do they have the building blocks to be able to heal that wound? So that's kind of our overall goals when we're looking at this. But you can definitely see there are some very different appearances of these, okay, these different wounds. And you think about arterial, it's because of a lack of blood flow. Now, that being said, when we talk about a lack of blood flow, for many of these patients, this has been a progressive chronic disease. So the circulation for peripheral arterial disease has been compromised for quite a long period of time. Okay, so, you know, the toe didn't turn black in one day. It's not a sudden occlusion or a sudden lack of blood flow that you might see with compartment syndrome, okay, that we talked about back in Unit 3. These are generally progressive, so it will start with, you know, the legs becoming pale. Eventually, for arterial disease, it goes on, they will get cyanotic, they will get blue, they will eventually get necrotic if you let this go. Sounds kind of gross. I had a friend that I went to nursing school with. She was an LPN coming back for her RN. And she told me about the time she was working in a nursing home, and literally they were helping to bathe a patient, and he had severe peripheral arterial disease. Really should have had some amputations, but just wasn't a good surgical candidate. And, you know, he and the family just opt not to do it. And they were bathing his foot the one time and the toe fell off. So that would kind of gross me out, but it can happen. You know, necrotic things do fall off. All right, so another comparison, and this is right from, I can't remember if it's from the pre-class capture or if this is in the class PowerPoint, but I'm just brought it over here as well. So with arterial, again, you have that progressive decrease in blood flow to the extremities. They can develop what we call intermittent claudication, which is where they develop some vasospasms and decrease circulation with activity. Usually it's about after 20 to 30 minutes of activity, and they start developing the cramping and the real pain in their legs. And at that point, they need to sit and take a break. So we call that intermittent claudication. As I mentioned before, their pulses will be diminished or perhaps absent. If they are, sitting dependently and you're getting the blood flow down there, they might have some dependent rubor. But again, when you think about an arterial problem, I don't want to always elevate their legs, because if I'm elevating their legs, it might be more difficult for that blood flow to get down there. So you have to kind of watch with this, and you would never elevate their legs above heart level in arterial disease. As we mentioned, the dry, shiny, cool skin, lack of hair, specifically lack of hair on the toes for our male patients. That's usually a really good sign that things are happening from an arterial standpoint. Again, with the arterial ulcers, it's typically going to be on the toe, on the heels, pressure points. They also tend to be very painful. But again, they're very deep. They're circular. They're not necessarily over, wide in diameter. They tend to be smaller circular, but they tend to go deeper. And these wounds will have that eschar tissue. Obviously, we're looking at trying to promote arterial circulation. Now, on the venous side, again, looking at the differences, your venous patients, their pulses are going to be present. They're definitely going to have edema. Their skin, because of all of that pooling of the blood and the pressure, the skin actually develops a thickness. It's very tough, kind of really hard. Kind of reminds me of like elephant skin. The ulcers that we see with venous, the most common place you're going to see them is on the medial malleolus. That tends to be the most common place they see. But again, they tend to be more superficial. They're not going to be deep the way the arterial ulcers are going to be. And your venous ulcers will have an irregular border, and the wound bed itself will have that granulation tissue. They can be painful. Arterials usually are very painful. Venous ulcers, it can vary. Your patient can have very minimal pain to very severe pain. So it just varies. And also, again, with the edema, not only from the wound, but from the poor circulation as well. Now, again, regardless of what we're talking about, an arterial or a venous ulcer, our goal is going to be to reestablish skin integrity. So we want to promote wound healing. Part of that, as part of every nursing care plan that you ever do, you're going to have interventions that will probably be similar, arterial and venous, but you need to have an intervention that addresses the cause of the problem. So if the patient's ulcer is arterial, we got to have some interventions that are specifically aimed at promoting arterial circulation. If it's a venous ulcer, we need to have some interventions specifically aimed at promoting venous return, trying to avoid that venous pooling, okay? But both of these are going to have a focused integumentary assessment and a focused neurovascular circulation assessment as part of their interventions. So again, you're going to have some things that are going to be across the board, but you always have to look at the differences, and what's different is addressing that underlying cause, okay? So shout out for those of you doing CP2, whatever diagnosis you pick, you need to have an intervention that addresses the underlying cause of the problem. More on that later in the other session. Okay, edema present for both. So edema is always going to be present for the venous ones. For the arterial ones, they will only have dependent edema. So if you have their legs in a downward position for a long period of time, for example, if your patient's sitting up most of the day, just the way you do, if you're sitting at your computer all day, watching your Zooms, doing your work, and you go to take your socks and shoes off at night, your feet might be a little bit puffy. That's that dependent edema. That's why you need to get up and walk every so often. Pump that blood, pump that circulation. okay? Continuing on with the leg ulcers, again, the treatment is going to depend on the cause. If there is a potential infection there, we're going to start with oral antibiotic therapy, okay? Compression therapy is appropriate for venous ulcers only, okay? I would not want to use stockings or compression therapy with arterial ulcers because that's going to further diminish the circulation to those legs. Okay, so very careful with arterial. Remember, the problem is getting the circulation down there. So I don't want to do anything that's going to hinder that. You know, crossing the legs is harmful for both arterial and venous. From an arterial standpoint, if I'm crossing the legs, I'm limiting circulation distally to that cross. From a venous perspective, if I'm crossing the legs, I'm inhibiting return of that blood. So you got to teach them. They can't be crossing their legs. You can't be doing that. Okay. Wraps, again, depending on what we're talking about, if it's a compression wrap, never, ever, ever for arterial. We will likely use those for venous to try to help promote that return. For the actual dressing, for the actual wound itself, there will likely be a dressing. Again, if you go back to your basic principles of wound care, okay, if a wound is dry, it's completely dry. Now, if there's eschar necrotic tissue, that has to be debrided first. But if you have a dry wound or a dry skin issue, whatever dressing or whatever treatment modality you're doing has to add some moisture to it because you need to have a balance. You need to have some moisture there that promotes wound healing, but not too much that can promote infection or maceration, okay? So if it's a dry wound, you're going to use a dressing that's going to add a little bit of moisture. If it's a wet wound, I'm going to use a dressing that's going to absorb some of that moisture. Again, we're all about creating the perfect healing environment, very much like Goldilocks and the Three Bears. Okay, too wet, it's a problem. Too dry, it's a problem. We need to be just right. I did mention debridement. The hyperbaric oxygen chamber has been very helpful. It increases the amount of oxygen in the blood. We're ideally providing more oxygen to the wound bed to hopefully promote healing, okay? And I did mention wound vac therapy. That's sometimes used as well. Our goal is also going to be to improve their physical mobility because mobility is going to help promote circulation and venous return. Now, depending on what's going on when you're first seeing this patient, I did mention these are chronic problems, so this is something they're going to be dealing with quite a bit. Patients with vascular disease, specifically venous disease, tend to experience bouts of cellulitis. So you might be seeing this person as an inpatient because they have a cellulitis. You might be seeing them as an inpatient because they have something else. Maybe they have pneumonia, they have a COPD exacerbation, but they also have a venous ulcer that we're having to manage. So depending on what's going on, if it's cellulitis at first, or we think there's some sort of infection there, initially they might restrict some of the activity of that limb, but we want to progress to activity because we want to promote blood flow. So even if they can't get out of bed, we do want them moving in bed, doing those ankle flex or the ankle pumps and the ankle circles, just promoting blood flow there. Pain management is definitely an issue. Nutrition, I cannot emphasize enough, nutrition is so important here because if their body doesn't have the building blocks to promote wound healing, we can use dressing changes all darn day. We can give them antibiotics all darn day. But if they don't have the building blocks to promote healing in that wound, we're never going to get anywhere. They're not going to progress. Okay, so kind of tied to vascular disease, and we use this a lot, particularly for peripheral arterial disease. And if you haven't checked out the pre-class capture and watched that, there's some really good pictures in there that show you the progression of plaque buildup in the arteries. And this unit focuses on that in relation to the peripheral arterial disease, but that same process is what happens with coronary artery disease, cerebrovascular disease. So when we talk about these concepts of PAD, they're also the same ideas that lead to a heart attack or lead to an ischemic stroke. Okay, so it's really important that you kind of look at this from a broad perspective, because this is going to circle back in Unit 6. So when we talk about medications for peripheral arterial disease, one of the things that we will use is a group called antiplatelet aggregates. Okay, so that they do exactly what they sound like. They basically keep the platelets from sticking together. And I like to say it makes the platelets more slippery. It's harder for those platelets to clump, to form a clot. Okay, doesn't mean that they can't form a clot. It's just going to take longer for those platelets to do so. So you will often see patients on aspirin therapy. This is very common as a prophylactic measure against heart attack and stroke. The 81 milligrams once a day, the 325 milligrams once a day, not the higher doses. And we talked about this back in Unit 3, differentiating, are we using this for pain management? Are we using it as an antipyretic for the aspirin? Or are we using it for the antiplatelet aggregate factors? Okay, so, and that's what we're doing here. So other examples of this would be your clopidogrel. This is your Plavix, pretty commonly known medication, okay? And the other one up there, the brand name for that is going to be your Agrinox. All of these are aimed at promoting blood flow. We're trying to prevent clots that can affect the circulation to anywhere in the body, but for peripheral arterial disease to the lower extremities. Okay, so adverse effects of this, we did talk earlier in the semester about aspirin being part of the FAB4 that can lead to gastritis. So the nausea, vomiting, the dyspepsia, the gastritis. That's why if we're using aspirin therapy, we ideally for chronic aspirin therapy want to use an enteric-coated tablet. Okay, we also want to teach them to swallow it whole, and if possible, you really need to be giving it with food. Okay, so as you're learning these medications, you know, you'll notice the chart on the screen has adverse effects, and then underneath it has nursing implications. Really tie these together. Okay, so because this medication causes GI issues, what am I doing as the nurse to try to prevent those? I'm trying to be, you know, preventative here. You'll also see concurrent use of PPIs, your proton pump inhibitors. For patients on chronic aspirin therapy, that is pretty common. Now, again, you have to weigh the benefits versus the risk, because long-term proton pump inhibitor therapy also has its own side effects and issues. But again, you look at what is going to kill your patient first. Okay, so our other big side effect we worry about is bleeding. Okay, so it's kind of like the seesaw you used to play on back in elementary school. Okay, you know, we're trying to balance this out. I don't want my body to be able to form clots all the time, because that's going to block circulation, but I also don't want my body to spontaneously bleed, okay, because then I can die of hemorrhage, and that would not be a good thing. So we want to kind of balance that out. So the risk with antiplatelet therapy, one of the big ones is hemorrhagic stroke and your GI bleeding. The hemorrhagic stroke, that risk is going to be much higher if your patient has hypertension and it is not controlled. So to tie this into last class, it goes back to controlling that blood pressure. That is going to be a critical aspect of what we're doing, okay? GI bleeding, that can be anything from, you know, some bloody stools to some bloody emesis to even bleeding gums. So when you are talking about giving any type of medication that's going to affect coagulation, observing for signs and symptoms of bleeding is a priority nursing action, okay? So on the slide, you'll see neurological checks. That relates directly to the hemorrhagic stroke. If your patient has a bleed in their brain, okay, you are going to see some neurological signs. We'll talk much more about this in Unit 6 when we actually get into both types of stroke, but understand you're going to see neurological changes. You also want to watch for coffee ground emesis. That indicates that there's bleeding in the stomach because that blood has come into contact with that hydrochloric acid. There might be bloody stools, and that could be anything from bright red blood to like a maroon color to the black tarry stools. You're looking for bruising, ecchymosis, petechiae, bleeding gums. usually with your antiplatelets, you wouldn't likely see bleeding from like IV sites and stuff like that. But with other types of medications that affect coagulation, you would also want to look at any type of devices, you know, Foley's, IV access, anything like that. This medication can result in hearing loss. Again, that's typically with either high doses or for long-term doses. So there have been cases where patients have taken low-dose aspirin and developed hearing loss when they've taken it over a span of many, many years. Again, at that point, you're looking at the benefit versus the risk. And obviously, because this is going to increase your patient's bleeding risk, that's why it's discontinued several days prior to any type of elective surgeries. If it's an emergent surgery, you know, if we can put off the surgery, great. If we can't, it's emergent, they go to the OR and we deal with it. In that case, if they have issues with bleeding, we'll use things like clotting factors and fresh frozen plasma. Okay, warfarin, Coumadin. Okay, this is a big one. This is always a classic on boards because it is so widely used. It's widely used because it's cheap. However, it does carry some significant risk, and there's several things that you need to know in relation to monitoring and client teaching. Okay, let me check the chat box here. Okay, how many days should it be DC'd prior to surgery? Generally, they say 5 to 7 days. If your patient's having elective surgery, that would be part of the pre-surgery instructions that they would get, you know, as to what medications they could take the morning of surgery, what things they need to stop, and when they need to stop them. Anticoagulants, aspirin, typically a week, but also consider other things like herbals and over-the-counter supplements because they can also cause issues with bleeding. Great question. Okay, so for warfarin, this is going to block the synthesis of vitamin K dependent clotting factors. So that's why the antidote or the counteract for this is vitamin K. Okay, so warfarin, the important thing to understand is this is a medication that has a longer onset of action, a longer duration. So if I took a pill of Coumadin today, you are not really going to see the effect in my blood for at least 3 days, probably closer to 5 days, which is why with the Coumadin prior to surgery, they generally stop it 3 to 5 days prior to surgery. Okay, so this is going to take a while to work. This is also why if you've taken care of a patient in the hospital that's maybe developed a DVT, we'll treat them with something like enoxaparin, Lovenox, or sub-Q heparin, and we'll start that right away, but they're also on Coumadin. So they're technically on 2 anticoagulant medications, but they're only going to be on that enoxaparin, that heparin, until their Coumadin becomes therapeutic. Okay, so you do see that. And it's important for us to be able to understand that, to be able to explain it to your patient, because they'll be, well, they started me on Coumadin, I have a clot. Okay, why are you coming at me with an injection? Okay, so they need to understand how those things work together. And if I don't give that injection until that Coumadin gets therapeutic, they're at risk for developing more clots or that current clot of getting bigger. Okay, now Coumadin is used for a variety of things. You know, we're talking about it in relation to DVT, you know, and arterial issues, but anything that's going to put your patient at higher risk for clot formation means we're going to be looking at some form of an anticoagulant, whether it's a direct thrombin inhibitor, you know, or something else. We need something that's going to reduce the risk of clots. So common reasons you might see a patient on warfarin: atrial fibrillation, probably one of the #1 reasons, because with the atria, when they're not nicely contracting, when they're just kind of quivering, they're fibrillating, that blood is sloshing around in there. Very high risk of developing clots that will then move down into the ventricle and get pumped out. From the right ventricle, it gets pumped to the lung and they can have a pulmonary embolism. From the left ventricle, it pumps out, it's going out. Every time your left ventricle pumps, approximately 25% of what it pumps is going directly up your carotids into your brain. So if you think about that, that's why AFib is one of the critical risk factors for an ischemic stroke. Because if this patient's not anticoagulated and they have AFib, essentially they got a 1 in 4 shot of having a stroke every time the heart beats. Okay, so that's pretty significant. If your patient has a prosthetic heart valve or valvular disease, that just means that there's more likely to form clots on those valves, so they would be on some sort of an anticoagulant. And of course, MI, strokes, that sort of thing, because we're trying to prevent it. And then of course, not so much prevention of DVT, PE initially, but if somebody has had a DVT or a PE, they're likely going to be on something like warfarin long-term to prevent recurrence. So our biggest adverse effect with this, as I mentioned before with the aspirin, is the bleeding. For warfarin, the test that we monitor is going to be the PT and the INR. Now I have INR as 2 to 3 there. That's a general range. If your patient's on Coumadin, we generally want their INR between 2 and 3. However, in certain cases, so for example, the prosthetic heart valve, if it is a mechanical valve, okay, not a tissue valve, an actual mechanical valve, we'll probably want their INR between 3 and 4. Okay, we want them, you know, a little bit more anticoagulated. But in general, we're looking between 2 and 3, always at a minimum of 2. In fact, that's usually the criteria for your patient who's receiving both heparin or enoxaparin and Coumadin. The INR level of 2 is usually the criteria that they can come off the sub-Q and just be solely on the warfarin at that time. Again, vitamin K is the antidote. So one of the key pieces that you need to know and you need to teach your patient is they need to have a consistent consumption of dietary vitamin K. Years ago, when I was in nursing school, we used to tell patients they couldn't have, you know, they needed to avoid vitamin K as much as possible. That actually was a problem too, because, you know, you need to have that balance. Because warfarin has such a long duration, once you, onset of action and then duration, once you take that pill, the bigger critical piece is consistent consumption of that dietary vitamin K. So it's not, oh, well, it's Sunday, I go to the family and I eat a huge salad and then I don't eat any greens for the rest of the week until the following, you know, Friday, Saturday, Sunday. That's where it gets more difficult to keep a consistent level of warfarin, a therapeutic level in the blood. Okay, so that consistent piece is going to be really important. Obviously, if you're using warfarin with anything else that can affect bleeding, it's going to increase the risk for bleeding. So aspirin, acetaminophen, because acetaminophen affects the liver, and you remember the liver makes your clotting factors. So if your patient is on medications that strongly affect the liver, or maybe they have some underlying liver disease, that's a concern. Certain antibiotics can also increase those anticoagulant effects. There's also medications that decrease the effect. The two big classifications are going to be your oral contraceptives and your anticonvulsants. In fact, oral contraceptives by themselves, because they alter the coagulation of the blood. Oral contraceptives, specifically if they're taken by women over the age of 35, 40, that actually is a major risk factor for the development of DVT. That's one of the reasons we don't like to use them in women once they're that age. There's some other options that we can use. It's not always the best choice. But that's an OB conversation, not for me. All right, so our parenteral anticoagulants, and I'm focusing mostly on heparin here. We did cover heparin back in Unit 3 in relation to subcutaneous heparin. That's commonly given subcutaneous, either heparin or subcutaneous Lovenox, in order to prevent a DVT post-surgery, post-orthopedic surgery. So now when we're talking about heparin, we're talking about this from an IV perspective. Okay, because if your patient has developed a DVT or a PE, we're now at the IV point. Okay, sub-Q is not, well, particularly PE. If they have a DVT, a lot of times we could still use the sub-Q. But if it is moved, if we have a PE, we're now at the IV point. Okay, we're none of this sub-Q stuff. So what you will see your IV heparin used for, in some cases, an evolving ischemic stroke. Again, we'll talk more about strokes in the next unit, But obviously, if the stroke is a bleeding stroke, we would not want to give an anticoagulant. With PE, as I mentioned, if there's a massive DVT, like this is a large DVT or they have multiple DVTs, they're not going to opt for the sub-Q. We're going to go to the IV. DIC, that's more of a critical care level thing. We're not going to go there right now. But I want you to kind of think about your adverse effects here. We have that risk for hemorrhage. Okay, well, that makes sense. It's an anticoagulant. But what you have to understand is this is an IV infusion, an IV bolus of heparin. So we're delivering it directly into the circulation. It's going to start working very, very quickly. Now, that being said, it also means that if we shut off the heparin drip, it will reverse itself fairly quickly. So when you have patients who have to go to surgery and they're on IV heparin, and it's not an emergent surgery that they have to go like right this minute, we will typically stop the heparin drip about 4 hours before the time of surgery, and they'll be okay to have that surgery. So that's the positive aspect of that. If your patient has to be on Coumadin prior to surgery, they cannot, be off that Coumadin. They'll have them stop taking it usually about 5 days before surgery, but usually a day or two before surgery, they might have the patient come into the hospital and they'll put them on a heparin drip because their risk of being off that Coumadin is just so great. Okay, so hemorrhage is a big thing. Hypersensitivity, particularly heparin-induced thrombocytopenia, you might hear that abbreviated as HIT, or it's also known as heparin-induced platelet aggregation, or you might hear them say something about a patient, oh, well, they're HIPAA positive. Okay, they're not talking about the Health Insurance Portability Act, okay? This isn't about a confidentiality thing. This is an adverse effect of heparin therapy. It can happen with sub-Q heparin too, but you're going to see it more pronounced with IV heparin, where the platelets, it starts destroying the platelets. It causes platelet aggregation and a reduction in the platelet count, which then further puts that patient at risk for bleeding, spontaneous bleeding. And also if they would have an injury, if they cut themselves, it would be much more difficult for that blood to clot. So we're going to get into calculations here in just a minute, but just some basics first. When you're having IV heparin, because it works fairly quickly, we have to monitor lab levels to make sure we're giving them enough heparin that they're anticoagulated enough, but that we're not giving them too much that we put them at risk for spontaneous bleeding. So when we talk about changing a heparin drip, we use the term titrate. So we're going to titrate this heparin drip, the amount, how many units per hour, and what that converts to on the pump milliliters per hour based on these lab values. So they're usually either using PTT or they're using unfractionated heparin, factor 10A, they'll look at as well. But there's some sort of protocol in place that they're using to evaluate the patient's blood work to determine, are they anticoagulated enough or are they too anticoagulated? Okay, so it's very much a balancing act with this. Oh, great question. Is HIPAA reversed after the heparin is stopped? Yes. So once we stop the heparin, the effects might persist for maybe a day or so. Because remember, when your platelets are formed, your platelets have a 5 to 7 day lifespan. It will start correcting itself. It won't be fully corrected usually for about a week though. Okay, so we will continue to monitor the CBC to check that platelet count. And that's actually the third thing there under nursing implications, watching that platelet count and really trending what's happening. So when we look at the heparin protocol on the screen here in a minute, there's information there that you need for the calculation, but there's also a lot of information there that's part of the protocol for monitoring, and we'll discuss that then. Protamine sulfate is the antidote. You got to know that. If you're giving vitamin K to somebody who's getting IV heparin, that was just a waste of vitamin K. Obviously, anytime you're using this with any other anticoagulants, antiplatelets, it's going to increase the risk for bleeding. And as I mentioned before, the sub-Q, the enoxaparin or the sub-Q heparin, those need to be given subcutaneous in the abdomen. You want to stay 2 inches away from the umbilicus. Those are typically dosed on weight. We do not monitor PTT levels with sub-Q heparin. So this is just something you want to keep in mind moving forward when you're doing clinical work for the next class, everything. When you pick out those priority points for administration, you really want to tailor them to what is being prescribed for your patient. So I mentioned this in the respiratory thing, okay? If you look up albuterol and it's a meter dose inhaler, one of the things it's going to tell you to teach your patient to do is to have them prime their inhaler, do a puff first to make sure it's primed. That doesn't apply if you're giving it via nebulizer, okay? So when we talk about heparin here, if it's sub-Q heparin, we are not drawing blood to monitor their PTT. Okay, that is specifically for IV heparin. The subcutaneous injections, particularly the enoxaparin, the Lovenox, patients can be taught to self-administer them at home. And a lot of times we will do that. A patient will come into the ER, we will diagnose them with a DVT. Obviously, we'll rule out a PE first of all. We'll get them started on that first dose, get them started on that first dose of Coumadin as well, and teach them how to give those Lovenox injections at home, or teach a family member, because then they can do that at home. Obviously, teaching them reportables and emergent signs and symptoms is critical, but that's a way we can keep the patient out of the hospital and in their own home environment where, we're not worried about them picking up an infection in the hospital. Oh, great question. Can low molecular weight heparin, like enoxaparin, cause the HIPAA-2? Yes, it can. Yes, it can. But again, you're giving it subcutaneously, so it gets absorbed over a longer period of time. So usually you're not going to see as big of a drop in the platelets, but it can happen. If somebody's going to develop this because they have this hypersensitivity, it's going to happen whether it is sub-Q or it's, IV. With using these sub-Q, we're generally using them sub-Q for a shorter period of time. So even if they go home on warfarin therapy and we're using enoxaparin until they get therapeutic, we're generally not going to be drawing their blood watching for that platelet count. Part of our teaching will be to teach them for signs and symptoms of bleeding, because if their platelet count is dropping, they are likely going to have ecchymosis, they're likely going to have petechiae and some other signs of bleeding. So that's a really big piece when it comes to teaching your patients about any type of medication that's going to alter their coagulation. Good questions. All right, so we're going to get into heparin problems here in just a minute. I just want to say a couple things about this slide. And I put this slide in here and in the class PowerPoint for a reason, and in the online worksheet. Heparin is considered a high-risk medication. So if you go back to basic pharmacological principles, that means there's a high risk for injury to the patient if something goes wrong. So for IV heparin, it's a high-risk medication. And when you are starting a heparin drip, when you are titrating a heparin drip, making changes to a heparin drip, that needs to be checked by 2 licensed nurses, one of whom must be an RN. Some facilities require it to be 2 RNs. Some facilities are okay with an RN and an LPN, but they have to be 2 licensed individuals, and the one person for sure has to be an RN. So I want to make that point. The other point that I want to make, and this is another reason why it's considered a high-risk medication, is because heparin comes in multiple concentrations. So when we make you do those 3 checks and we make you read aloud from the actual package, the concentration, we're doing it to prevent errors like this. As you can see on the screen, the first one is heparin 1,000 units per milliliter. Right next to it is 5,000 units per milliliter. Okay. Sometimes they're multiple use vials and it's still 1,000 units per milliliter, but there's 10,000 units in 10 milliliters. So you can see there's a lot of numbers on here that really predispose it to some potential errors. I'm just talking about adult dosing. We also have heparin vials that contain 10,000 units per 1 milliliter. Okay. Those are the ones we use for adults. Heparin is also used in all age groups. Back in, I want to say it was the late 90s or the early 2000s, and it was a hospital in Indianapolis. I almost want to say it was Indiana University, I'm not sure. But in their NICU, there were 10 babies that were overdosed on heparin. And when they traced it back, the heparin was being used just to flush IVs. It wasn't actually being given to the patient that way, but it was being used to flush IVs to keep it open. What went wrong was the wrong concentration, the wrong strength of heparin was stocked in their Pyxis. The screen read correctly, okay, the screen read correctly, but what was actually stocked, I think it was supposed to be 1 unit per milliliter, and what was actually stocked was 10,000 units per milliliter. Something that should never ever be on a NICU. That's just not an appropriate dose, but it was an error. And unfortunately, when those doses were pulled out, those nurses, it happens. You know, we are human, but sometimes we get complacent. And, you know, well, who in the world would have anticipated that 10,000 units per milliliter heparin strength would be stocked in the NICU? And their normal dose is always 1 milliliter because we're giving 1 unit through the IV to keep it open. Okay, they did that. Patient, obviously, these babies were severely overdosed. And it was all because the wrong concentration was stocked. Now, obviously, it started with a pharmacy error, but it continued with a nursing error because they did not look at the actual package that they were pulling the medication out of. So learn from that mistake, you know, learn from that situation. Of those 10 babies, 6 of them died. And 2 of them had very long lasting problems. They actually developed ventricular hemorrhages in their brain. Okay, brain hemorrhage. So this is really serious. That's why heparin is considered a high risk medication. It's just really, really important that we do it right. So that's the heparin vials. The other label that's on the screen there, that heparin sodium 25,000 units per 250 milliliters, that is for the actual IV drip of heparin. I will tell you what the label that's up there is the most common concentration of heparin. However, I have also seen 50,000 units per 250 mLs. Or no, I'm sorry, scratch that. I've seen 25,000 units per 500 mLs. Okay, so you really need to be very careful looking at your concentration. That's also a very important piece for the calculation part of it that we're going to get into just here in a minute. But I just really wanted to emphasize really looking at your labels. Okay, when your instructor has you read out loud, we want to make sure you're doing those 3 checks. We can't read your mind. You know, I want you to say, okay, I am ordered to give heparin 5,000 units sub-Q every 8 hours to Jane Doe at 8 o'clock. I'm looking at the vial. I have heparin sodium for injection, 5,000 units per milliliter, and my expiration date is, and talk out that calculation. That's why we have you do that. It's a patient safety issue. So getting into calculation, and do not let calculations, heparin drip calculations, freak you out. I have some students who are like, oh my God, it's heparin. It's no different than what you were doing before. There's 2 extra steps. That's all. It's really not. And if you think about calculations, that is the only black and white thing in nursing. Okay, there's only one way you do it. Or let me rephrase that. You can do it different ways: ratio, proportion, formula, dimensional analysis. But there's one correct answer to this. Okay, there's no wishy-washy here. So when we talk about calculating heparin, there's 2 types of calculations: the initial calculation and the ongoing drip, where we're titrating. Okay, so for you, that just means you need to look very carefully at what you're doing, what you're giving, and what the concentration of your supply is. And I have it in red: your bolus supply and your infusion supply, your concentrations are different. Okay, they are different. So you really need to pay attention to that. And I'm going to point that out when we look at the actual screen that shows you the protocol. Just to clarify, because a question that I've got from students, because obviously there's going to be dosage calc on the exam. Doesn't take a genius to figure out what kind of dosage calc we're talking about here. So to answer your question, the heparin protocol will be provided for you. It will be on the exam. You do not need to memorize the heparin protocol, nor should you memorize the heparin protocol, because depending on what facility you're working in, the protocol that they are using might be a little bit different. The concentrations they use, whatever, it might be different. So you should not be memorizing the protocol. What you should do is understand what the protocol is, how to read it, how to interpret it, and how to implement it in your patient, okay? It is not to be memorized. Okay, that being said, let's kind of keep on going here. All right, so looking at this protocol, and I'm just gonna step back for a minute. We'll get to the calculation piece in a minute, but I just wanted to link back to what I was saying before. So on your protocol there, number 3 talks about an APTT level every 6 hours or 6 hours after the rate change. And then that's daily after 2 consecutive therapeutic APTT levels. So this links back to the monitoring and how do we titrate the dosing of the heparin drip, okay? You'll see number 4, it talks about CBC initially and then repeat every so many days. A lot of times you'll see that every 3 days. That's kind of pretty common, the every 3-day thing. So we're looking at the CBC, but what we're really looking at is that platelet count. We're looking for that heparin-induced thrombocytopenia, okay? You can see guaiac stools. Okay, well, why would we do that? It increases the risk for hemorrhage. If they're going to bleed, 90% of the time, it's going to be from somewhere in the GI tract. So we want to check those stools for blood. Neuro checks every so many hours while on heparin. Again, risk for hemorrhage. We're looking for the potential that maybe there's bleeding in the brain. Okay, so those things are there. They're part of the protocol. You don't need them for the dosage count piece, but you can see how they tie in directly to the side effects and the adverse reactions of an anticoagulant. Okay, all right, enough about that. Let's get into the actual calculation. So one of the things that I would recommend on your blank piece of paper when you do this, and you get to the heparin problem, look for the information that you need and write it down, okay? You need to know your client's weight, okay? It will likely be given in pounds, so you're going to need to know how to convert it to kilograms. So if you remember your basic equivalent, it's 2.2 pounds equals 1 kilogram. So if you have your patient's weight in pounds, you're going to divide it by 2.2 to get it in kilograms. If you're not sure if you need to divide or multiply, always think about it this way. I like to report my weight in kilograms because the number's smaller, okay? So you need to know that. You also need to know, depending on what your problem is, are you doing a bolus or are you doing an infusion, okay? So in number 2, in the protocol, it says heparin 25,000 units in 250 milliliters of half normal saline. Bolus is to be given as 1,000 units per milliliter. Those are your concentrations. If you're using the formula method, the desired over half times quantity, that's your half in quantity. Okay, 25,000 in 250 and 1,000 in 1. Okay, so it's very important because if you're doing a bolus problem and you put the wrong supply dose in there, you're going to get a totally goofy answer. Okay, you also need to know for an initial, we're getting this started, you need to know the initial dosing, which is in number 10. It says bolus with 80 units per kilogram, start drip at 18 units per kilogram per hour. Again, you have a bolus calculation and you have an infusion or a drip calculation. So you need to find the information that you're looking for. Okay, so let's take a look at an example. And this was right out of the capture, but let's just talk through it. If I follow those steps, my client weighs 180 pounds, which converted when I did my calculation, it was 81 kilograms, but I have to round it to the nearest 10. So I'm going to base that on 80 kilograms. And I do want to point out, this is for adults. This, you would not round to the nearest 10 kilograms if we were dealing with a child or, a neonate. Okay, this is for adults. So we have the 80 kilograms of weight. My bolus order is 80 units per kilogram. So I'm going to have 80 units times 80 kilograms to figure out what I have to give for the bolus. Okay. I know what my bolus concentration is because it's in number 2. My infusion order, okay? It says 18 units per kilogram per hour. So I take my 18 units multiplied by my 80 kilograms times 1 hour. That's how I get my desired, or what I desire to give, okay? So really the only extra 2 steps are converting the weight and you calculating out what the desired is if you're doing the formula desired over half times quantity, you know, because it's based on your patient's weight. It's not going to be the same for a 90-pound patient versus a 240-pound patient. Okay. All right, so as I mentioned before, 80 units times 80 kilogram, I need to give 6,400 units of heparin as my bolus dose. Okay, that's great, but for me to give the bolus dose, I have to be able to pull it up in a syringe and give it IV push. So how do I figure out 6,400 units in milliliters? Okay, well, I desire to give 6,400 units. What I have for my bolus concentration is 1,000 units per 1 milliliter. So I calculate that out to 6.4 milliliters. I clean off the vial, I pull it up in my syringe, I can pull up 6.4. Remember your rounding rules here, because it's over 1 milliliter, I'm pulling it up in a syringe, I can go to the tenths. Okay, I would not round this to 6 milliliters. It is 6.4 milliliters. And I give the bolus. All right, so for my infusion order, my order was 18 units per kilogram per hour. So I take my 18 units times 80 kilograms times 1 hour, and I need to give 1,440 units per hour. Okay, pumps though are set in milliliters per hour. Now, I know there's some really cool smart pumps out here now. And yes, you can actually, in the smart pumps, you can program that this is heparin and this is what my concentration is, and this is the number of units I'm supposed to give, and it'll calculate it for you. You can set it in units per hour. On NCLEX, we are assuming that you cannot. Okay, so to figure this out, I have to set my pump. My pumps run in milliliters per hour. So I want to give 1,440 units per hour. My concentration for my infusion, remember it's different than the bolus, my infusion is 25,000 units per 250 milliliters. So if I do that calculation out, it's going to be 14.4, okay? Depending on what type of a pump you're using. If you're using one of the new smart pumps, yes, you can program in 14.4 milliliters per hour, okay? If you're using one of the older pumps, and you know, right now, today, with everything going on with COVID, these hospitals are taxed. They only have so much equipment. You may actually see some facilities up on the regular units, not with COVID patients, but up on the regular units using some old school pumps that they've pulled out of the warehouse. If it's an old school pump and it can't do those tenths, it's going to be 14 milliliters per hour. Okay, so what I did here, I basically, on your heparin worksheet that was part of the pre-class prep, I worked the problems for you, okay? I did, for the final answer for the infusion rates, I did round them up, but I showed both. If it, again, was a smart pump where you could do a 1/10 of a milliliter, you would be able to program that in. If not, it would need to go to that whole number. But again, we're following the same process. You know, where we're converting the patient's weight to kilograms, we're rounding it to the nearest 10, we're calculating the bolus dosage in units, we're calculating the bolus dosage in milliliters. And then we move on to the actual infusion. Again, these are 2 different things, the bolus and the infusion. So you can kind of see that. I'm not going to go through number 1 because we kind of just went through the example. What I do want to point out is number 2. So we talked about how the heparin will be titrated based upon the APTT results, okay? So your patient, you've bolused them in number 1, you've started the drip in number 1, we're good to go. So 6 hours after you started that drip, we're gonna come up and draw blood from that patient, and we're gonna get an APTT result back. Based on that result, we are going to titrate that drip. Okay, And unfortunately, when I did this slide, I didn't put the protocol back in front of me, but I'm going to go back a couple slides just to kind of show you there. Okay, so on the protocol that's there, you'll look at numbers 11 through 15. Those are going to tell you how you titrate the drip. So if your APTT is less than 35 seconds, this is what you're doing. If it's between 36 and 44, this is what you're doing, and so on and so forth. So your initial starting it, that is the only time you are using number 10. Okay, after that, everything that you do titrating this heparin drip is going to be based on the titration pieces 11 to 15. Okay, so I'm just going to jump back ahead here really quick. All right, so here the APTT result was 36.8. So if I looked at that protocol, I need to rebolus the patient and I need to adjust the rate. So the rebolus rate is a little bit less. I'm following the protocol. I'm supposed to give 40 units per kilogram. I don't change the weight. And that's something else you know. When they are calculating a heparin drip, they are going to be basing it on the admission weight. If you would happen to have a patient who came in like with massive heart failure and they are so fluid overloaded and then we start taking fluid off, that would be the pharmacist and the provider may end up recalculating things. But for the most part, your standard adult patient, you are going to be basing this on the admission weight. Okay, so the weight doesn't change for your calculations. So the 40 units times the 110 kilograms, that's where you get your rebolus dose, 4,400 units. When you calculate it out, it's 4.4 milliliters in the syringe. When you are changing the rate, you are always making the change based upon the previous rate. So in number 1, we started the rate at 18 units per kilogram per hour, okay? The protocol for this tells us to increase the rate by 2 units per kilogram per hour. So if I was at 18, I'm increasing by 2. I'm now at 20 units per kilogram per hour. Okay, so that's where I get my new, I need to give 2,200 units per hour, and I do my calculation. It ends up being 22 on the pump. Okay, let me check out the question in the chat box. Okay, rounding rules. For bolus doses over 1, it gets rounded to the nearest 10th. That is correct. For infusions, they always get rounded to the nearest whole number. Yeah, that's fine. It's going to depend in real life, you know, what type of a pump you're using. And honestly, 19.8 versus 20, you know, from a perspective, it's not going to make a whole lot of difference. It really is going to depend on what pump you're using. I would say if you were answering this question on ATI, or if you're answering this question on boards, a lot of times it may even say round to the nearest 10th, but usually ATI does. Boards has updated and is changing. Last that I heard, they were starting to go to using the 10th for the pump rate. So, you know, 22.4. What do I want for the exam? It would be a multiple choice question, so you'd be able to figure that one out, okay? And that's the reason I do that, because this is changing. What I would definitely tell you to do is moving forward, when you guys get to Med-Surg 3 and you are getting ready to graduate, that is definitely something that we want to clarify with the boards at that time. Like, how is NCLEX grading at that time, so you can be prepared for that. Okay. Oh, great question. Patrick, you're already getting ahead of me. Would the next calculation be based from the last one or the original? It's always based from the one before. So once I titrate it up to the 20 units per kilogram per hour, okay, I made that change on the pump. I rebolus this patient. Now, 6 hours from making that change, I'm going to do another blood test. We're going to get another PTT result. Okay. So now for number 3, it's now 6 hours later. Okay. And I need to move this so I can see. Okay. So now the APTT is 92.3. I don't have the protocol in front of me, but I'm pretty sure that's the one where I have to stop the pump for a while before I restart it in an hour and then decrease it. But again, if I'm taking care of a real patient with this, I'm not going, I think that's what the protocol says. No, I'm looking at the physical protocol myself and another licensed nurse to verify what it is that we're doing. So on the protocol, we need to reduce the rate. It says decrease by 3 units per kilogram per hour. So you're basing it from the current rate that you have now. So the current rate we had now was 20 units per kilogram per hour. I need to decrease it by 3 units per kilogram per hour. So now I'm at 17, okay? Again, I do my math, I do my calculations, I get 18.7. If I had a smart pump, that's where I'm going. If I have a dumb pump, old school pump, dinosaur pump, 19 milliliters an hour. Okay, so I wanted to show you 1, 2, and 3 in succession because this is literally what happens with patient care. We get it started and then we're titrating it based upon those lab values. Now, the next couple ones, I have it per a custom protocol. I've never really had to do this a whole lot as a practicing nurse, but I just wanted to show you this, how your numbers would change if your supply dose was different, okay? So number 4, it's a custom protocol. Well, okay, 20 units per kilogram per hour, that looks okay. My infusion concentration looks the same, 25,000 and 250. But what's different? Look at my bolus vial. Now, instead of 1,000 units per milliliter, it's 5,000 units per milliliter. Okay, that's fine. My process for calculating the problem isn't any different. I still follow the same process, but now look at my concentration. So I have 9,900 units divided by 5,000 units times 1 milliliter. Now, here we go. Now I calculate it out and I have 1.98. I have to round to the nearest 10th. Well, the nearest 10th on that 9 is going to bump it up to 2. So that's why you have 2 milliliters. But you see how that's very different. If I go back to the previous, even though we're talking 2 different weights, just look at the volume difference. So I calculated 2 milliliters for the bolus. This person's bolus up in number 1 was 8.8 milliliters. So you can see how the volume and the amount of medication you're giving is very different. So watching that concentration is absolutely critical. Okay, and that's why I threw this one on here for you as that custom protocol. What's custom about it is your bolus strength, because I wanted you to see the gravity of, if this nurse didn't really look at the protocol, oh, well, they're always 1,000 units per milliliter and I'm giving 9,900 units. If they went with that calculation, they would have pulled up 9.9 milliliters and gave it to the patient instead of 2 milliliters. So just think about how much additional heparin that would be and how dangerous that is for your patient. Okay, so pretty serious. Same concept with number 5 and number 6. What's different about number 5 is just simply, it's a continuous infusion, but you'll see it's 25,000 units in 500 milliliters instead of the 25,000 in 250. And, you know, when you're looking at this, you take a look at this, it's definitely going to change your pump rate. So that's what I really wanted you to pay attention to with 4, 5, and 6. On Play-Doh, I actually have this answer key as a document. I will post that on Play-Doh so you can actually check it. But again, I just wanted you to give you that experience and emphasize how important the supply concentration is when you're doing these calculations. Again, here, number 6, your available bolus vial is 10,000 units per milliliter. So if my bolus dosage is 2,000 units, if I was using 1,000 units per milliliter, I would be giving 2 milliliters. But this is 10,000 units per milliliter, so my dose ends up being 0.2. So you can see how if you're not looking at this, your patient can literally get a 10 times overdose if you're not careful. If you're not following those 3 checks and verifying that concentration and making sure you are using the correct concentration in your calculation. Now, I did have some, as I was looking through your pre-class preps, there were some things off on the challenge question. And I'm not going to have a challenge question like this, but I just want to briefly show you. It's the same process, but I wanted to give you an example of the difference between heparin and some of these other medications. when the heparin protocol was ordered, it was so many units per kilogram per hour, okay, per hour. When we're talking about this medication, we are talking about milligrams per kilogram per minute, okay, per minute. So very important with that, you have to account for the hour because the pumps are programmed per hour. So I'm not going to spend a whole lot of time on this. Like I said, it will be on the PowerPoint, not the PowerPoint, I'm sorry, the answer key that I put up on Play-Doh. The process is still the same. I still have my dose times my kilogram, but this is per minute. So I need to do times 60. So I really could do 2 milligrams times 100 kilograms times 60 minutes, which is going to give me, and that is a typo. That should be milligrams right there. That should be 12,000 milligrams per hour. And then from there, I'm still following my same problem. I'm still doing, I desire to give 12,000 milligrams per hour. What I have in my concentration is 250,000 milligrams in 100 milliliters, okay? Let me look at the chat. Okay, so, okay. Oh, I have it on microgram. Okay, wow, yeah, that's totally a typo. That would be milligrams. So I will put this. Conversion from micrograms to milligrams to grams. Remember, there is a 3 decimal distance difference between all of those, okay? A lot more zeros, yeah. So again, I put that on there mainly because it uses the same type of concepts as the heparin. What you will see on the exam is heparin, so please don't get freaked out on the challenge question. All right, so let me actually open up the chat. Before I go into ABG review, let me open up the chat and kind of start at the top and see if I addressed everything. What I have left here is I have 3 ABGs we're going to go through and talk about, and I have 4 NCLEX questions. So let me kind of address any questions. And it looks like there's a lot in the chat here. So let me kind of go down and see what we have here. Okay. Okay, in the COPD case study, there was a question that asked what the priority intervention was for a patient with wheezes and an SpO2 of 92%. The answer was to administer the PRN DuoNeb, but there was an answer choice to sit the patient up, which was incorrect. Unit 5 Jeopardy, there's a similar question, but the priority intervention was to sit the patient up. What is the difference in these questions that made the DuoNeb come first? How do you differentiate? So I have to kind of look back at the Prep U question. The thing that stands out to me in the Prep U question, as it's described here from the student, is that there are wheezes, okay? So that tells me at that point, you have the wheezes, you've auscultated, you know there is airway narrowing, okay? So the purpose of giving the DuoNeb is to help open up those airways. Now, that being said, without having the question right in front of me, and I can't look at my Jeopardy right this second. I'm not quite sure what the options were. That being said, if you're giving DuoNeb, you need to kind of sit your patient up, okay, in order for them to get the maximum effect. I'm going to tell you, if I'm doing these things, I need to sit that patient up first. So that would be an instance where Prep U and I disagree a little bit there. First thing you want to do is sit that patient up. They may or may not need a breathing treatment. And some patients, their SAT might be down because they're laying in that position and they're just not taking deep breaths. And maybe sitting them up is going to solve the problem. With what's presented here, the fact that the patient has wheezes, just sitting them up is not going to address, take care of the problem. But it is still the first thing that I would do. I'm sitting them up as I'm starting to give that DuoNeb, as I'm getting things set up, checking their ID band, getting it in the nebulizer, and getting that treatment in them. So I'm still going to say you sit them up first, because if you're giving a treatment, that's going to help them get the most out of that treatment. If a patient is on a heparin drip and starts having adverse symptoms that indicate bleeding, do you stop the heparin drip first or prepare to administer protamine sulfate? You're going to do both, but you're going to stop the heparin drip first. This is kind of the same concept in relation to fluid overload, the same concept in relation to a transfusion reaction. You want to stop the causative factor. So the first thing I'm going to do is stop that heparin. we're likely going to give protamine sulfate if that's our order. And again, if it's listed there in an NCLEX question or an exam question, it is a, it's an option. You have the order for it. But if you think about it, in the time that it takes me, maybe it's only a couple minutes, but in that couple minutes that it takes me to prepare the protamine sulfate and administer it to the patient, if I let the heparin keep going, that the issue is still happening. So I need to stop that heparin drip first, okay? And then I have the order for protamine sulfate, I'm giving that, okay? Again, on an NCLEX question, it's only you, okay? You are the nurse, the buck stops with you. In real life, if I'm working with this patient, I'm stopping the heparin drip and I'm asking my other RN, my charge nurse, to go get the protamine sulfate and get it prepared so we can give it. But when you're looking at it from a testing perspective, you are the only nurse. The buck stops with you. All right, are we gonna go over heparin questions? Oh, viscosity in relation to heparin. I'm not quite sure what that was about. Okay, thromboemboli and thromboembolus. Okay, emboli just means it's plural. I have multiple, and embolus is singular. Okay, so I have one. Now, that being said, you can have one, thrombosis or one embolus, and it could potentially break up into smaller pieces. So it can very easily become more than one. Can the AP perform the Doppler color flow duplex? No, an AP, when we talk about an AP, that is your nursing assistant. And when we talk about Doppler color flow duplex, this is something that an ultrasound tech or cardiovascular tech is going to be performing. This is not something the AP does. What would be a nursing diagnosis for someone with peripheral arterial disease? Ineffective peripheral tissue perfusion would be a great one because they have the problem getting the circulation down to their toes. Okay, are we supposed to apply a heating pad if they have a DVT? Okay, well, so here's the issue with that. When you apply heat to something, it causes vasodilation. So I would not put the heating pad on the leg initially, okay? Because initially I don't want to cause the vasodilation. I don't want it to break off. I don't want that to happen. Now, do keep in mind your body's natural process. Your body makes and breaks up clots all the time. So that clot that formed, in about 7 to 10 days, it's going to be completely dissolved. Maybe even 10 to 14 more. It's going to be completely dissolved. So the purpose for giving the anticoagulants is to keep additional clots from forming or that clot from getting bigger. Okay, that's our goal with that. With the heating pad, if you put it on right away for pain management, it causes vasodilation. You could potentially take the risk of the clot breaking off. As they get more anticoagulated, the docs don't really seem to be concerned with that as much. So you could potentially use heat therapy for that. Now, that being said, keep in mind, anytime you're using heat therapy, particularly on the lower extremities, you really need to be aware of arterial circulation problems and like people with diabetes, the neuropathy, because that can sometimes cause more problems than it's worth. Okay, so generally heating pads on the lower extremities, on the very lower extremities, not so good. I have heard where they have used like heating pads on like the upper thighs and in the lower abdominal area to try to cause vasodilation up in the larger vessels to promote circulation to the extremities. But really heating pads on the extremity, not such a good idea. Okay. All right, let me keep going here. PrepU says don't take ASA while you're on warfarin. Yeah, that really is a rule of thumb. Now, I know one of you is probably sitting there saying, but I had a patient at clinical that was on both. I have two. I have taken care of patients that have been on both aspirin, and warfarin, or they've taken warfarin and they're also on an NSAID. Here's the thing with those patients. The benefit for that patient outweighed the risk of bleeding. Okay, that's not the case with all the patients, and it is a good general rule to not take aspirin while you're on anything that's also going to affect bleeding and your blood's ability to clot. But again, The provider that makes that determination is going to look at the benefit versus the risk for that specific patient. And it's going to be, you know, based on them, you know, what is the bigger risk for that patient? Okay, I think I addressed the one on the edema. I think I did that back there. Let's see here. HIPAA reverse, we did rounding. Okay, I think. Okay, so I don't want to call you out, Reagan, but I'm going to call you out. So what do you mean about thick viscosity and thin viscosity? Can you, I'm not quite sure what you're asking. So if you could clarify that, I can address your, I want to address your question. I want to make sure I'm answering your question. I'm just not quite understanding what you're asking. So.
Okay, so in my notes, I put blood viscosity, how thick the blood is, and then I put an example. So if a patient isn't well hydrated, they'll have less plasma, more cells and solutes, and the blood will be sticky. So.
Okay, I gotcha. Perfect. Okay, I gotcha. So when we talk about viscosity and we talk about how thick or how thin it is, basically it's how hydrated a patient is. So the more hydrated a patient is, the more space, the more plasma there's going to be between the red blood cells and between the platelets. So if I have more space between the platelets, they're not as likely to clump together. That's why patients who are dehydrated or fluid volume deficit are going to be at higher risk for developing clots. And that's why one of the things that we can do to help prevent clots is to make sure your patient is well hydrated. Okay, thanks for that. I wasn't quite getting it, but you know, now that I know what you were asking, you know, did that answer your question?
Yes, thank you.
Okay, perfect. All right, I'm going to move on to the ABG review. Do continue to put questions in the chat box. I know we're running over here a little bit. I'm sorry for my CP2 people. We'll pick up the CP2 right after this in a separate session. Okay, ABG review. Want you to look at the ABG results below. Let's think about what the acid-base imbalance is and what the presence of and level of compensation. So is there compensation? Is it fully compensated? Is it partially compensated? Or is it not compensated at all? All right, so let's go through this together. pH is 7.35. Okay, so if you think about your normal values, and one of the things that I would recommend, you know, if you struggle with remembering those normal values, that's something you want to brain dump on your piece of paper. Okay, pH 7.35 to 7.45. Okay, well the pH is 7.35. That's normal, right? It is normal, but which side is it leaning towards? Is it more acidotic? Is it more alkalotic? Okay, 7.35 is more acidotic. So we know we're probably looking at an acidosis here. Okay, look at the next thing, PaCO2. My normal range is 35 to 45, and my result here is 58. So it's high, it's abnormal. It's the CO2, so it's my acid indicator, and if it's high, that leads towards the acidosis. So now I have the pH going towards the acidosis. I have the PaCO2 going towards the acidosis. So I know this is going to be a respiratory acidosis. Okay, I just need to figure out, do I have compensation? So now I look at the HCO3 and it's 32. So my normal range is 22 to 26. This is high. Okay, but when you think about your bicarb, okay, that is your metabolic indicator. Okay, that's your base indicator. So I'm looking up, that's elevated. Okay, so that's going in the opposite direction. That's going in the alkaline direction. So if I wrote this out, I got the pH is acidic, the PCO2 is acidic, and my bicarb is going towards the alk. Okay, again, we look for the two that matches. So I know I have a respiratory acidosis. Because my bicarb is abnormal, moving in the different direction, I know that there's compensation. Okay, that's great. There's some compensation. Looking at my pH, it's back in normal range. So this is considered fully compensated respiratory acidosis. Oh my gosh, there we go. There we go. Fully compensated respiratory acidosis. Okay, so now let's stop and think for a minute here. What type of patient would have a fully compensated respiratory acidosis? And I want you in the chat box to tell me what patient, what disease process do you think would have fully compensated respiratory acidosis. Okay, let me take a look at the chat boxes here. Oh, look, you're coming in. Okay, so I see a lot of COPD, and you're correct, but tell me about the COPD patient. Is this somebody you would see actively in the hospital, or is this somebody you might see at an outpatient clinic here for a checkup? What do you think? Who would you see this in? Oh, not as many brave souls this time. Okay, those of you that put stable as an outpatient, you are correct. You are correct. This is your stable COPD patient, okay? They are always going to be respiratory acidosis, but because it's a long-term disease, they're stable, their compensatory mechanisms are working, they're generally gonna run fully compensated. Now, that being said, fully compensated, they're gonna run like very close to 7.35. There may be times that they even dip 7.34, 7.33, okay? But these patients, this is your stable COPD patient. Now, this is just based on the numbers here, okay? Obviously, when you look at these numbers, you also need to look at your patient in real life. Do the numbers match what I'm seeing with this patient, okay? All right, so let's look at the next one. Now I have 7.32, okay? So on the pH side, I know that is acidotic, okay? Because I am out of normal range, okay? Out of normal range. So I know for sure nothing is fully compensated because my pH is outside of normal range. All right, my PaCO2 is 62. Wow, that is really up there. I'm going towards the acidic side. So because of my pH, I know I definitely have a respiratory acidosis. I have a respiratory acidosis, absolutely. I look at my bicarb. Okay, it's 29. That definitely is elevated. It's moving towards the alkalytic side. So there is some level of compensation happening. But when I go back to my pH, I'm not fully compensated because while the body's starting the process, we're not completely there yet. So this patient is your partially compensated respiratory acidosis. Okay, partially compensated. Again, because my bicarb is moving in the different direction, but my pH is still out of whack, and that's why it's only partially compensated. All right, so throw it up there. What kind of patient is this? Who is this? Who would you see these results in, or this type of reading in? Only 2 brave souls. There you go. There you go. Congratulations to those of you that got it. COPD exacerbation. So this is your COPD exacerbation. There's still that respiratory acidosis, but now there's an acute thing going on. So the compensation that was happening isn't enough. Okay, so that's why it's partially compensated. So yes, this is your COPD exacerbation. Give yourselves a pat on the back. All right, one more. All right, use the ABG results. Let's figure it out. 7.28. Okay, acidosis. Okay, we're acidotic. And then I'm going to have one more after this. I don't have a slide, but we'll talk about it. Respiratory acidosis. Okay, I know it's 7.28. It's acidosis. My CO2 is elevated again. So again, we're looking at a respiratory acidosis. And the reason I put the respiratory ones in here is because this unit is oxygenation and perfusion. We're dealing with respiratory. So this is a respiratory acidosis, but let's look at the bicarb. 24. It's normal. There's no compensation here because with compensation, the bicarb would be moving in the opposite direction. It would be trying to increase to balance out that pH. Okay, so this is truly uncompensated respiratory acidosis. Now, in the chat box, who is this? Give me an example. I mean, there's several things that could happen, but give me an example. Who would this be? Who would have uncompensated respiratory acidosis? Oh, I'm getting a couple takers now in the chat box. What do we got here? Okay, so some good questions here. This would not be hyperventilating. This could be respiratory failure. this person has a significant impairment in ventilation, okay, of ventilation and diffusion. So this would be something that you would see in a patient who is not getting enough oxygen in and they're not expelling the CO2, a very acute situation. So this could be a COPD exacerbation that's a very serious COPD exacerbation that they're getting to the point of respiratory failure. This could also be somebody who has overdosed on narcotics. So they have an issue with ventilation. They're not breathing. Maybe they're not breathing at all. Maybe they're breathing, 4 times a minute. It's definitely not enough to bring oxygen in and pull CO2 out. Okay. So there's a lot of different options here. Sleep apnea, not so much sleep apnea, mainly because the patient does take a breath then. For you to truly get to a pH of 7.28, they would have to be hypoventilating continuously. Now, your sleep apneas, because it's a chronic condition, you would probably more likely see respiratory acidosis with some compensation. Okay, so what did I do here? There we go. Okay, so opioid overdose, somebody, acute respiratory failure. Before I move on to the NCLEX question, I do want to clarify and address, too much morphine post-surgery. Yeah, that would be a really good one. So in this week's VSIM case, okay, Vernon Watkins, the guy with the PE. So initially, when you were taking care of him and you drew the ABG results, hopefully you drew the ABG because that was part of your orders after you contacted the provider. When you drew the results, his pH showed 7.47. Okay, why do you think that is? What did you notice about him in that scenario? What was his breathing like initially? What was, think about his respiratory rate and his anxiety. He was breathing very quickly. So I think somebody had mentioned before about hyperventilation. Yes. So when you have somebody who's hyperventilating, they're breathing very quickly. They're blowing off that CO2. So that's why it becomes a respiratory alkalosis. Now, here's the thing with this. He's not going to be able to keep that up for very long. I mean, he might be okay for, 20, 30, 40 minutes, but eventually his body's just not going to be able to keep up with that. And he starts crashing, and then it's going to change into a respiratory acidosis. But initially he was hyperventilating. So what's my favorite word? Casey Rambo, why? Why? What's my favorite word? Okay, why was he hyperventilating? Let's think this through for a minute. He had a PE, so that area in his lungs was not getting perfused. Okay, it was not getting perfused. So there was an area in there where there was no gas exchange taking place. So what the body tries to do is, okay, well, if that area of the lungs is not working, the rest of us got to work a little bit harder to try to maximize the oxygen that is there. So that was the body's natural response. Hey, this part's not working. I'm going to start breathing faster in an attempt to try to take more oxygen in. Now, the negative aspect of that is, as I'm taking more oxygen in, I'm also blowing off more CO2 when I exhale. So that's why your PE patients initially will show a respiratory alkalosis. But if we don't intervene and we don't address their oxygenation status and they start tanking, they're going to move to a respiratory acidosis just simply because their body cannot keep up with that demand. And now you're moving into an acidotic state. So I just wanted to clarify that, that you can initially see, yes, overcompensating for that dead alveolar space. Very good. All right. Okay, NCLEX questions. And I know you'll love this one. It says select all that apply. I know you're probably throwing darts at my picture right now, but that's okay. All right, so go ahead and take a look at this question. Go ahead and answer it in the comments, and then we'll kind of talk through it. And we'll talk through it, not just what's the correct answer, but how did we get there? Okay, how did we get there? And I do have rationale for these, so you'll be able to see that too. Okay, so the nurse is caring for a client admitted with a COPD exacerbation with copious secretions. Which intervention should be included in the plan of care to promote airway clearance? Select all that apply. Okay, so first things first, let's look at that question. Who is our patient? Well, it's somebody with a COPD exacerbation, but what about them is pretty important for you to note. What do they have going on? Copious secretions. Okay, if you don't know what copious means, okay, and that might happen. You might come across a question, you're like, what in the heck is that? I don't know, but there's, if I'm not quite sure what it is, but there's something, okay, I got some secretions. They have a lot of secretions. They might be thick, they might be thin, but they got a lot, okay? All right, so I know my COPD patient has copious secretions. Which intervention should be included in the plan of care to promote airway clearance? Okay, and you'll see how I emphasize some of those words. What is this question asking? Okay, what the question is asking is, okay, what are interventions that are going to help clear the airway? Okay, so now that we've looked at that, put in your response. Look at your options and put in your response in the chat box, and then we'll kind of talk through each one. Okay, just want to kind of see where you're at. Okay, good, interesting, okay. All right, so let's go through and look at these. Okay, chest percussion and postural drainage. Okay, so this is where we're kind of, you know, methodically pounding on the chest a little bit to try to loosen those secretions. And postural drainage is the positioning of the patient to kind of help the outflow of secretions. So does that intervention address airway clearance? Yes, it does. Okay, all right. So let's look at B. So we like A. A is good. All right, B, administration of humidified oxygen. Okay, what's the key word in B? What kind of oxygen are we talking about? Kind of oxygen are we talking about? Humidified. Okay, so what is that humidification going to do to the secretions? Okay, think it through. Same type of thing. This is why we promote hydration in the patient. It's going to loosen them. It's going to thin them. So is doing the humidified oxygen going to help airway clearance? You betcha, because it's going to make it easier for them to cough it up. Okay, so that's really important. We're looking at promoting airway clearance. Okay, so we like B, A, B, C, or A, B. All right, C, coughing and deep breathing treatments, deep breathing after respiratory treatments. Well, yeah, okay, the respiratory treatment will help open up the airway. The coughing and the deep breathing will help like hack those loogies up. So that's a good thing. I like C. All right, so far I like A, B, and C. All right, administer methylprednisolone 80 milligrams IV push Q8 hours. Okay, methylprednisolone. Okay, so that sounds like a steroid to me. All right. So I know that steroids are going to reduce inflammation and they'll help open up the airway. Okay, I know it's going to open up the airway. It will help promote oxygenation. Does it do anything for airway clearance? Does it do anything for airway clearance? Not really so much. It is part of the plan of care for the COPD patient, but it's really not aimed at promoting airway clearance. All right, so let's look at E. Provide soft, easy to chew foods, high calorie liquids. Definitely something I'm going to do for a COPD patient. Does it relate to airway clearance? Does it relate to airway clearance? Not so much. So let's see. All right, so the patient has copious secretions, so we want to promote airway clearance. Chest physiotherapy, percussion, vibration, postural drainage, they work to loosen the respiratory secretions, making them easier to expectorate. The humidified oxygen, IV PO fluids will help thin the secretions for easier expectoration and coughing and deep breathing. The IV corticosteroids and promoting adequate nutrition are part of the plan of care, but they don't specifically address airway clearance. So corticosteroids themselves, they will help reduce the edema. And yes, by reducing the edema, you do open up the airway. but they themselves are not going to promote that airway clearance. If I'm just using that, it's not going to get rid of the secretions that are there. It's going to reduce the edema, the swelling, the mucosal swelling of the inside, the inner layer of your bronchi and your bronchioles, okay? Open surface area relates to airway clearance. Yeah, I put it this way, if I was using it, I got this question off of an NCLEX website. If I was going to use this question, I probably would not have necessarily picked the methylprednisolone. Like I would not have used that as a distractor because it is so close. But really, if you're looking at it, airway clearance and oxygenation are two different things, okay? So yeah, you're talking facilitation and promotion. So yeah, so when you think about the mechanism of action, the methylprednisolone, the corticosteroid, helps relax, or not relax, it helps reduce the swelling of the internal lining of your respiratory tract. So by reducing the edema, I'm opening up the airway, but it doesn't actually promote cough. It doesn't actually promote clearance of the airway of the secretions that are there, okay? So when I picked C and D, something causing pain. Okay, hold on. People are making comments, but I'm not quite sure what you're asking. Coughing and deep breathing. Okay, let me go back to the question. I'm not quite sure what you're asking, but just going through the coughing and deep breathing after the respiratory treatment. We give the respiratory treatment to open up the airway, and that's going to maximize the coughing and deep breathing. But the real key piece here is the coughing and the deep breathing, and that's going to help promote the airway clearance because I'm hacking up those secretions. So when you're looking at this question, you're focusing on the airway clearance. Should it always be after respiratory treatments? Put it this way, you should always have your patient cough and deep breathe after respiratory treatments. But if their respiratory treatments are only scheduled every 6 hours, it is beneficial for them to cough and deep breathe in between. So coughing and deep breathing is going to be effective in promoting airway clearance. Now, the timing of when it is the most effective would be after respiratory treatments. Okay, all righty. Next question. The nurse assesses a PPD MAN2 test on the forearm of a client in an outpatient clinic. This patient has a history of lupus and takes daily immunosuppressant medications. How should a finding of 3 millimeters of induration be interpreted? Okay, and you can see your options there. Is there an active TB infection? Is it negative? Is it, have they questioned the client if they've been exposed? Is it significant? So let's look at the question. What are we looking at? We have a finding of 3 millimeters of induration. Okay. And what do we know about this patient? They have a history of lupus and they take daily immunosuppressant medications. Okay. So if this is something you weren't sure of, I'm actually going to pop ahead to the rationale. This patient, because of the lupus, because of the immunosuppressants, they're considered immunocompromised. So if they have had 5 or more millimeters of induration, that's going to be significant, okay? In a healthy person with no history of autoimmune disease or immunosuppression, you need 10 millimeters of induration to be considered significant, okay? So that's important to know. Now, that being said, remember, the TB test, the PPD that comes back positive does not mean the patient has active TB. It is simply looking for the antibodies to a previous exposure. So you cannot say that the patient has active TB without a chest x-ray and without a sputum culture, okay? So I just want to really make that clear. I'm going to go back so you can see what the options were, okay? This result, 3 millimeters, and even in somebody who is immunosuppressed, is negative. It's not significant. Had this number been 5 or above, it would have been significant and it would have required a sputum culture or a chest x-ray, okay? If this was a healthy person, it would have to be 10 or above to be significant, okay? And again, this test by itself does not confirm the presence of an active TB infection. Okay, here we go. Nurse is caring for a client who is scheduled for a cardiac cath. Which assessment finding in this client is most important to report to the cardiologist? So think about it this way. Which one of these findings has the potential to harm the patient the most? Okay, to harm the patient the most, who's having a cardiac cath. So read through your options. Mild anxiety, depression, 2-day history of nausea, vomiting, a previous allergic reaction to barium, or your platelet count of 157. Put your answer in the chat box. Okay, put your answer in the chat box. There we go. Now I'm starting to see my chat box light up here. I got to figure out how to do like polls on here or something. I don't know. Oh my gosh, it looks like we're all over the board here. Okay, so let's work through here. Okay, I see a lot of D's. I see some C's. Okay. All right, so let's go through and take a look at this. They're having a cardiac cath. So I want you to think how they do a cardiac catheterization. Okay, they're going in through a vessel, generally in the groin or in the brachial area. They're going to thread the catheter up there. They're going to inject some dye in there, and they're going to visualize the circulation. Okay, so just kind of thinking through what that is. History of mild anxiety or depression. Okay, that would be good to know, but is that the most critical thing? No. All right, 2-day history of nausea and vomiting. What are you concerned about if somebody has nausea and vomiting for 2 days? Okay. What are you concerned about? Throw it in the chat box. What are you, there we go. Electrolytes, fluid and electrolytes. Okay. All right. So what is the problem if you have somebody who is fluid volume deficit if they're having a cardiac cath? Considering what we just said, how you perform a cardiac cath. What did we have to inject into them to see the circulation? Okay. The contrast. Okay. What are you concerned about with the contrast in somebody who's fluid volume deficit? What do you think? There you go. Kidneys toxing it out, AKI. There you go. Okay, so we're worried about the kidneys. All right. So, okay, B is kind of concerning. So I don't want to eliminate that, but I want to keep reading. Is there a better option? Previous allergic reaction to barium. Does barium have anything to do with a cardiac cath? What is barium? What is that? Do you remember that from unit, what was that? Unit 4, I think it was. Okay. Barium has nothing to do with the cardiac cath. It's that you can give it via enema. It's kind of that white, milky, chalky stuff that's really thick. We use it in the GI tract. So if they had a previous reaction to barium, that's not related to IV contrast. Okay. So that really, it's nice to know, but it's not going to impact the cardiac cath. So I can eliminate C. I've eliminated A, I've eliminated C. All right, platelet count of 157,000. Anybody remember what your normal platelet count is? Let me see, who popped that up? Let's see. 150 to 400,000. So their platelets are within normal limits. Okay, so is that something you need to report to the cardiologist? No. So in working my way through, B is going to be my correct answer. Okay, so let's look at the rationale. The cardiac cath is contraindicated, it could be, in type 2 diabetes, renal disorders, or dehydration because of the contrast material being nephrotoxic. Okay, reaction to barium, normal platelets are not contraindicated for the procedure. They're not contraindications for it. I'll typo there. All right. Is it a concern that they're on the low end of normal? Not really. It's still within normal limits. I would be much more concerned. And even if they were a little bit low, like let's say you were looking at a platelet count of 130,000, it's low, but it's not critically low. I would be much more concerned if they were below 100,000. So let's say they're at 130,000 and I'm looking at, okay, the platelets are a little bit low, okay, versus they are dehydrated. Platelets being a little bit low, it could cause a problem. Dehydration, if I give that contrast, it is definitely going to cause a problem. It is definitely causing a problem. So, you know, for that one, if I'm picking between those two, if the platelets were actually low, okay, well, let me rephrase that. If the platelets were slightly low, I'd still go with dehydration. Now, if you did the lab values and I told you their platelets were 17,000, the platelets are going to take, well, both of them would be high priority, but the platelets at that point, if it was that low, 17,000, would be a higher risk of killing your patient. Okay. Good questions, good thinking. Now, I just want to point out, let me go back to the question, okay? Because, you know, sometimes I'm a little devious and I like to do this. One of my hobbies in my spare time is writing NCLEX questions. I know, you're probably like, she's crazy. I am. But we just talked about D, and we talked about how D, the answer for this question can totally change based on a tweaking of a word in one of the options. If that, you got rid of the 7 there and that platelet count was 15,000. Wow, that's a big deal. Change barium to shellfish. That's a big deal. Okay, so I say that to you because I want to point out to you that it's really important for picking out those keywords and what is the question asking, but what does the response actually say? Okay, so here's my plug. If you haven't been on Nurse Logic, you need to be on Nurse Logic. You need to look at the critically reading test items and you need to look at the critical thinking and clinical judgment sections, because that's what's going to help you with how to approach these questions. And you might see a question somewhere that looks very similar to something you may have seen before. It's probably not the same. These questions can be tweaked and it can change things. If they had one episode of vomiting and it was 50 milliliters this morning, maybe they were a little anxious because they're having this cardiac cath. 50 milliliters does not dehydration make, okay? But the 2-day history, absolutely. So those details really do matter, okay? I just really want to point that out. It's important that you look at those things. All right, last NCLEX question. I had to throw something in delegation for you because, you know, we talked a little bit about that, I think, in the very first Zoom class, just kind of focusing on that. So what can you delegate to an AP for your post-op abdominal surgery patient? Select all that apply. Because I know you love the select all that apply. They're your favorite. All right. So I'll give you a minute, kind of look through there. Put down in the chat box what you think the answers are. And then we'll go through each of the options and we'll talk through this. What can your AP do? Okay. And just as a side note, it's important to understand as the RN, what can you delegate to your AP? What would be appropriate to delegate to your LPN? Okay. Because in the RN role, we're going to delegate to both. All right, let me check out some of these chat box of responses. All right. Okay, so it looks like everybody pretty much picked A. Okay, and yes, your AP can put on TEDs and they can put on SCDs. That is in their scope of practice. So A is a yes. Obtaining a blood glucose reading. That is a yes. Your APs can do blood glucose checks. Now, I will say in some facilities, the RN or the LPN might be doing that, and that's a facility-specific policy. When NCLEX tests you, they're looking at global, nationwide standards and norms. Okay, so it is the norm that your AP can do a blood glucose reading. So A is good, B is good. They can do that. Okay. All right, C, adjusting the oxygen flow rate from 1 liter to 2 liters. Absolutely not. Your APs really should not be touching that flow meter. Now remember, we're in the Magic NCLEX hospital and everybody works in their scope of practice, okay? So APs should not be touching that. Do I see it happen in real life? Yeah, I do. Do I see nurses, you know, say, up their oxygen to 2 liters? Technically, the AP should not be doing that. They can get in trouble for doing it, and technically, the RN can get in trouble for inappropriate delegation. So that's just something to keep in mind. You are in the Magic NCLEX hospital, and everybody works in their scope of practice. So C is a big no-no. All right, D, silence the beeping alarm on the IV pump. Okay. Can your AP touch the IV pump? No, they should not be doing that. Again, we're in the Magic NCLEX hospital. The AP should not be adjusting the pump at all. The only thing they should be doing with a pump is unplugging it from the wall to help your patient to the bathroom if they need to ambulate to the bathroom. And when they come back, they can plug the pump in. That is all they can do. They should not be addressing any alarms. They should not be programming anything. If it's beyond plugging it in and out of the outlets, the AP should not be doing it. So D is a big no-no. Okay, E, monitoring apical pulse and respirations. This is the one that, just looking at your responses, some people picked E, some people didn't. Okay, E is a no. And let's talk through why. There's 2 different things in there that tell me that no, the AP should not be doing this. And the first thing that tells me no, this isn't an AP thing, is the word monitoring. Okay, if you go back to the principles of NCLEX testing, there are certain buzzwords: assessment, teach, evaluate. Those are RN buzzwords. Okay, monitoring, reinforcing teaching, those are LPN buzzwords. So that monitoring right there tells me that it's the LPN level. The other thing that tells me this isn't appropriate for an AP is what kind of pulse are we talking about? Okay, it's an apical pulse. Okay, it's an apical pulse. Now, your nurse aides typically are not taught to check an apical pulse. They're taught how to do vital signs. They're taught the task. And something that I want you to keep in mind is many of you work as nursing assistants, regardless of what your title is, you know, AP, techs, PCT, whatever. And you are not the AP that I'm talking about. When you talk about what you can delegate to an AP, I want you to think about a very basically trained AP who completed the nursing assistant class, not somebody who is in nursing school and continuing their education. Okay, this is the AP right out of that class. They are not taught to do apical pulse. They're not expected to do apical pulse. So right there, I don't want to delegate that. Plus that word monitoring. So E is a no-no. So right now I have, for yeses, I have A and B. I have no, C, D, and E. And the last one, F, emptying the catheter and documenting output. Absolutely. That's something that an AP can do. So your answers, your correct answers were, gosh, I put a typo. That should say F. That should say F. I promise you it's F. It's not ABE, it's ABF. I must have changed something around on the slide. It's ABF. Okay, so NCLEX principle, monitoring is a buzzword, LPN scope of practice, and that apical pulse, that should be done by a licensed nurse. Okay, so I'm gonna stop sharing my screen, come back to me here. Wow, we really took a long, but that's okay, that's all good. All right, so last minute questions. Okay, let's put any questions you have in the Zoom group chat, throw them in there. I'm gonna answer that. Okay, what resources can we use for AP, LPN, scope of practice principles? Your ATI foundations book. I don't remember what chapter it is, but there is a chapter in there on delegation. And there's actually a really, really nice table in there that shows what can be delegated to an AP and what can be delegated to your LPN. And now you do need to always take that with a caveat, okay? Because yes, I can delegate vital signs to my AP, but you also need to think about the other principles of delegation. Is it an appropriate delegation based on the circumstances? So if I have an unstable patient, that is not somebody I should be delegating vital signs, vital signs on to an AP. Okay, if I'm taking care of a patient with continuous bladder irrigation, that is not something, the actual calculation of what the real output is, I should be delegating to the AP. Okay. If it is a patient with aspiration precautions, they have swallowing difficulty, they have known swallowing difficulty, and that patient needs fed one-on-one, that really should not be an AP doing that feeding. Okay, so take a look in that fundamentals book, in the ATI fundamentals, there's a chart. Those are your general guidelines. But again, you need to look at the circumstances of the particular situation. Is it appropriate to delegate with that or not? Okay, let's see here. What was the answer to the second question? Okay, hold on. Let me go back and look and see what the second question is here real quick. I think that was the TB one, the PPD test. And the answer to it was that it was negative. It was insignificant because the induration was only 3 millimeters. And for an immunocompromised patient, it has to be 5 or higher to be considered significant. Postural drainage. With postural drainage, that refers to positioning of the patient in different, just in different positions. And a lot of times they might be Trendelenburg, reverse Trendelenburg on the sideline. And postural drainage generally goes along with chest physiotherapy or chest percussion. So they position the patient in a certain way. They do the chest percussion, the chest physiotherapy. And not only does the chest percussion loosen the mucus, but because of how the patient's positioned, gravity helps facilitate drainage down, I should say rather up towards, to be able to expectorate it. So a lot of times they just position patients in different ways with pillows, and it just helps facilitate the movement of those secretions so that when they cough, it should be easier to get that up. LPNs and APs can reinforce teaching. No, technically LPNs can reinforce teaching. Now, that's not to say that APs don't remind patients of different aspects, but if you're looking at NCLEX principles, teaching is RN, reinforcing teaching is an LPN. And again, I'm focused on that is NCLEX principles. The reality is your LPNs absolutely do teach your patient. Your LPNs absolutely do assess their patients. But just from an NCLEX perspective, when you're looking at terms and buzzwords, if it's reinforcing teaching, that is an LPN scope of practice. Okay. All right. Any other last minute questions? No. Okay. All right. So I'm going to stop this recording. Those of you that want to do the CP2 thing, give me 5 minutes and go to the same link or the other link. I will be there, but just give me 5 minutes. I got to get a drink. Okay. This recording will be uploaded to the class YouTube channel. And then for those of you that are continuing with the CP2 one, just like I said, give me 5 minutes and have a great weekend and a very happy Easter. Stay safe, stay healthy, and enjoy the times with your family.